Welcome to the University of California, San Francisco Sports Medicine Podcast featuring Dr. Nirav Pandya, Dr. Brian Feely, and Dr. Drew Lansdowne discussing hot topics in sports medicine and society.
Go ahead and get started. All right, welcome everyone to the UCSF Sports Medicine Podcast, 6 to 8 weeks with myself, Dr. Nirav Pandya, Dr. Brian Feely, and Dr. Drew Lansdowne. Today we'll be covering a very common pathology that many of you hear about and may have actually know someone or suffered the injury yourself, an anterior cruciate ligament tear. It's an injury we see a lot in weekend warriors, as well as professional athletes, as well as young patients. So it's definitely something that we need to know a lot about. So Brian, maybe I'll start with you. I mean, even though we are going to talk a lot about the surgery and what we can do, I think prevention is usually the best thing that we can do. So how do you prevent an ACL tear from happening in the first place?
Yeah, I think ACL tears fall into two general buckets. I think they fall into the absolutely unpreventable and the possibly preventable. And the absolutely unpreventable are you're playing a contact sport or collision sport like basketball, football, soccer, and someone just runs into you on a planted leg while you're trying to turn. And I think no matter how much training you do, how much prevention you try to do, you can't avoid that in these sports. I think the preventable ones are much more complicated, but there is a subset that are probably preventable. And I think things that we look at in terms of minimizing the forces on the ACL are often kind of due to preconditioning and getting in shape prior and during the season. So important things are getting your core stability as good as possible, strengthening your quadriceps relative to your hamstrings. And there are programs out there such as the FIFA 11 that have been shown to be really beneficial in decreasing injury risk. Do you all use that or similar programs with your patients?
Yeah, and I think that there is good evidence to support that a lot of these, exercise-based programs can help decrease injury risk. And like you're saying, some of these are just inevitable. Like you can't prevent everything, especially when you're, active and putting yourself at risk. But you can minimize the injury, and especially for, I think, our, high school athletes, college athletes. And I think anytime we see them emphasizing, make sure that you're keeping up with these types of strengthening, plyometrics, balance exercises, and then it'll help them, perform better, but then also help decrease that injury risk too.
Yeah, I think one thing that we don't talk about too much with ACLs, but is really important, especially in the high school level athlete, is fatigue. And we see this in a lot of the endurance studies that you look at what happens not when you're just in clinic doing a single test when we see, let's look at your single leg squat, let's look at your double leg squat, but what happens after you've played 5 soccer games or you've played a season of volleyball and now you're starting your beach volleyball or your outdoor volleyball season. And that fatigue and that cumulative athletic exposure is probably more important. And Nirav, you've done a fair amount of work with this in terms of early sports specialization and rest. We know that the NBA has really embraced this idea of rest and giving people breaks. How do you try to translate that to your youth population?
Yeah, that's a great point. I think for a lot of these kids, I think there's both kind of rest, during their season and then kind of cumulatively over the year. And I think one of the things that's really important is having kids play multiple sports. And the reason why that's important is that, if a kid's playing basketball year round or playing baseball year round or soccer, then what ends up happening is those muscles get fatigued from the constant, skill-based kind of sports that you're doing. So what may happen by the end of the season or even at the end of a game, they're fatigued and then their body basically breaks down and then they have that traumatic injury. So I kind of like to tell my kids the ACL is a static structure, but you move dynamically. And when all those dynamic things start getting fatigued, then you're putting your ACL at risk. So I think the way that kids can do it is, number one, not play too much at any one setting, whether it be a weekend, whether it be over the course of a couple of days. And then over the course of a year, make sure they're changing their sport. So those muscles that do become fatigued can then get rested in an active sort of way. So I think that's really, really important for the younger population.
Yeah, I think it's always hard to convince people that haven't had an ACL injury before. You have to do this pre-prevention for something that may never happen to them. But one thing to consider is 1 in 9 basketball, soccer, and volleyball female athletes in high school will tear their ACL. So convincing your kids, yourselves, to do these prevention type injuries is probably really beneficial. So Drew, we talk a lot when we teach residents and fellows that you should know the signs of an ACL. So what sort of things when patients tell you what happened with an injury, do you hear and go, that's probably an ACL?
Yeah. So one of the more common things is seeing or feeling or hearing a pop. So this is, I twisted my knee and I felt a pop as soon as it happened. And that's pretty common in ACL injury. So that kind of tips you off that may have been what happened. Also, the people who tear their ACLs generally, they have a feeling that something really dramatic has happened to their knee and they don't go back to play. So a lot of smaller knee injuries, you twist your knee, strain something, and then maybe 15, 20 minutes later, you feel like I can get back out there and play again. But the ACL people kind of sense usually that the knee's not right, I better not go back, or I start to go back and just really know that leg isn't where it's supposed to be. And then another point is swelling in the knee. So after an ACL injury, the knee will swell up quite largely most of the time, and usually pretty rapidly. And so when we hear, I felt a pop, my knee started swelling about an hour afterwards, kind of know that that's most likely the direction that we're headed.
Yeah, I think that's absolutely true. As a veteran of 2 ACL tears, I can tell you it feels like a pop. It feels like something shifts. And even by the time you have your colleagues drag you off the court, your knee's already starting to swell. The thing I usually ask for our skiers is, when did it start to swell? Before you got in the car coming home from Tahoe or after? Nirav, is it any different for kids? I think we often see that kids' injuries are missed. So how do you look for things differently in your patient population?
Yeah, I think the one interesting thing in kids is that a lot of times they can suffer an ACL injury or even have a partial tear and they won't have that tremendous amount of swelling. Or a lot of times you get an 11, 12-year-old, they won't know that a pop has happened. So I think for a lot of kids, what will happen is they may present 3, 4, 5, 6 months later and their parents will say, look, their knee may be giving out or they're kind of falling over a little bit more. And I think kids don't get that big inflammatory response. So I think that's a little bit of a different thing you'll see with them. A lot of them may say their performance is decreasing down and they'll be bad one weekend and the next weekend they'll be able to play. So, and we'll talk about exam in a little bit. That might be a good transition, is that one of the things I like to do in clinic is kind of compare the knee side to side, because sometimes you can tell that something may be torn, even though they're feeling well, because you feel more laxity on one as opposed to the other side. So I think that's one of the key things that we'll look for in clinic with these younger patients who won't give that history that an adult may.
Yeah, absolutely. I think it's hard because by the time we see chronic injuries, people forget this, your knee actually feels fine without an ACL. So your ACL is only important in cutting and pivoting activities. So if you're going for bike rides, you're going for jogs, walking up and down stairs, doing your normal activities, you may not actually feel like your knee is unstable. It's not until you go back and play sports that you're actually going to feel bad. So the favorite thing I have my patients who kind of suspect, like, well, maybe it's not that bad, I have them watch Friday Night Lights, the movie, not the TV show, and say, watch the running back. He felt great exercising, but then as soon as he tries to pivot and cut and get up the field, his knee shifts again. And that's often what patients who feel unstable with their ACL act like. They feel pretty good until they try to do cutting and pivoting sports. So Nirav, you mentioned exam, and nature gave orthopedic surgeons one of each for the most part, so we could always compare side to side. What are the key things you look for on exam? And is there anything that patients can do at home to check whether or not they have an ACL tear?
That's a great question. I think in general, we don't encourage patients to get their children to test their own adult ACL tear. But I think, the things I look for on exam, obviously the basic things, you want to look to see if there's swelling there. You want to make sure that they, have any pain that may be suggestive of meniscus tear. But I think probably the best test to look for an ACL tear is something called the Lockman's test, where we basically bend the knee to 30 degrees and then try to translate the tibia, which is the shin bone, forward from the femur. And I think that's a very good test that we'll use. Obviously, the best time for us as sports medicine physicians is right on the field. When someone's muscles are pretty relaxed, it can be hard in the clinic because you can imagine someone has a painful knee and then we're going to come and move it along. That can be difficult as well too. But I think a lot of things we're looking for is swelling, how much motion they have, and if we can get someone to relax in the operating room, in the clinic, is whether they have more translation or that shin bone moving forward to the thigh bone on exam in clinic.
Yeah, absolutely. I think that's a great exam. Now, for those of you that wonder who actually invented that test or described the test, it's not Lockman. It was actually a guy named Dr. Torg, who's famous for a variety of different sports medicine things. but he named it after his chairman. So that means, Drew, when you discover something, that you need to call it the Vail test, which makes it sound like a ski-related injury. So,
Yes.
so Drew, you're our local expert in advanced imaging. What is the value of getting X-ray, CT scan, MRI, ultrasound in evaluating patients with ACL tears? When do we get them, and why do we get them?
Yeah, usually we will start with X-rays, as that gives you a good picture of the bony structure around the knee. And it's not uncommon to have really small bony injuries that you may actually even see better on X-ray than something like an MRI. So most of the time we'll start with the X-rays, and the fibula, some ligaments attached there, you could actually injure that at the same time as the ACL. Could have an injury to the kneecap or to the tibia, things like that. Or could just be a small fracture rather than an ACL injury that's kind of presenting in the same way. And then most of the time, though, the X-rays are normal for people with ACL injuries. And then we'll get an MRI. And I like to think that, we can detect the ACL injury on our exam. That's the most, or the best way for us to, tell if the knee's unstable is by, seeing if it moves and shifts. And the MRI is really to look for secondary injuries. So does this person also have a meniscus injury, a cartilage injury? Is there another ligament that's sprained or torn? And then, confirming that the ACL is completely injured. But rather than just looking at imaging, I think our exam is best to tell the ACL. But then based on those other injuries, we can really plan out, what the best treatment is for that person. So the MRI gives us the better visualization of all those soft tissue structures in the knee joint too.
Yeah. So when I was a resident, and I always bring this up when people say, well, why get X-rays? If we're going to get an MRI, why do I need to get X-rays? So I was a intern, so first year of training, and I had a patient come in. We were covering the VA hospital, and he was early to mid 40s, came in, had a hugely swollen leg. And he said, "Doc, I heard a pop, felt just like my ACL on the other side. And I just need to get an MRI because I know I had an ACL tear, get me set up with a sports medicine clinic." And I took a look at him. I didn't do the best exam that I should have. But I looked at him and said, "That's a really, really swollen knee. It felt like an ACL." He's like, "Yeah, felt just like the ACL on the other side." So I said, "Great. I know what to do. We're going to get you into physical therapy. We're going to get your range of motion back. I'll order the MRI, and we'll see you back in 3-4 weeks, and we'll get you all set up for surgery." And lo and behold, he comes back to sports clinic, and for better or for worse, I was no longer on the rotation. And I get this irate call from our sports attending who said, "You missed a quad tendon rupture. Why didn't you get an X-ray?" And the reality is that part of the reason we get X-rays is to rule out the obvious. What can feel like an ACL tear is actually a quad tendon rupture, but they're so swollen by the time we see it. Their patella would have looked low on that X-ray. Sometimes there's a fracture, especially in skiers. We'll see a little fracture on X-ray that it sounds like an ACL tear. They heard the pop, but instead we should be treating these acutely, not chronically. So I tell the patients the X-rays are actually really vital to help us make sure there's nothing else going on and not to miss something acutely while we let the knee calm down a little bit and wait for the MRI. Sometimes it takes a week to 2 weeks to actually get authorization and approval to get the MRI. Nirav, you want to add to this?
Yeah, one of the things with kids, because they're still growing, a lot of times what they'll do is when they present with a swollen knee, they may actually have a growth plate fracture. So you do see a good number of kids who come in who may have what we call a Salter-Harris fracture of the distal femur, where it can present like a ACL. And the problem with waiting for an MRI for that is that you typically, if that's the case, you want to get these kids in the operating room within a week. And what can happen is that suddenly they come back 2 weeks later with an MRI and the growth plate's already started to heal. You can't necessarily do the surgery on them. So in my pediatric patients, a lot of parents will say, "Look, we don't want to get the radiation on our kids. Can you just go to an MRI?" And I say, number one, we have to make sure there's not a fracture there, because there's a lot of injuries that can occur around the growth plate and make it seem like there's an ACL. Or sometimes what can also happen is that because the ACL is actually stronger than the bone in these younger patients, rather than actually have an ACL tear, their ACL can actually pull a piece of bone off, and it's called a tibial spine fracture. So it can present like an ACL, but we actually have to fix the bone back down. So once again, in the younger population, we're definitely ruling out some of the bony pathology that can present like an ACL injury.
Okay, so assuming a patient has an ACL injury, Nirav, what are your indications on who you operate on? Especially in kids, this is important because we're trying to limit further injuries and we don't know what they're going to do in the future. So are there times when you decide not to operate on them or wait? And since we're talking about it, are there times that you would want to operate sooner rather than later?
Yeah, so I think in general, with kids, maybe looking at 10, 15 years ago, because they have growth plates and there was a concern that ACL surgery could damage those growth plates. So there was the old thought that you wait until kids were done growing so then you could do an ACL surgery. But what we found was that if you don't have an ACL, number one, you can't tell kids not to run, play, jump, and pivot. They're going to do that. And when you look at the studies, they actually started having really bad meniscus tears, having more cartilage injuries. So really the trend now has gone to fixing these kids. I think in general, because of that, we want to save their meniscus and cartilage and we want them to keep them active. Generally, most kids will say, look, we want to go ahead and operate on you for these reasons. The only time I won't operate on kids is if I look at the family, I see the kid and they're very young, or they're not going to basically stick with the rehab, because that's the worst thing you can do is operate on a kid, then 6 weeks later, they've retorn their graft. So that's usually the kids that I won't necessarily operate on. I'll wait till the parent and family get a little bit more mature, can handle it. In terms of timing, I think the key thing, maybe just like with the adult population, you want to make sure kids have their full mobility and they don't have any stiffness. The only time I'll sometimes push for the operation is if they have a really bad meniscus tear that I have to get in there and fix. And sometimes they'll say, look, we're going to fix your meniscus, get your mobility back, and then come back 6 to 8 weeks later if they have stiffness. But usually for most people, I'm kind of looking at somewhere between the 5 to 7 weeks after the injury, let their swelling get down, get their mobility, and get them back. Is that similar for the adult population, Drew? Is that?
Yeah, I would agree. And, we want to make sure that the knee's kind of calm because after that injury, it gets really inflamed, swollen. And if you go in, rush in to operate right away, there's a good chance that it just stays that state afterwards or even gets worse. And so, working on motion and at the same time, working on quad strength, hip strength, core strength, all of that will help set people up for, a better outcome once we do get them reconstructed.
Yeah, so Drew, I'm going to ask you the opposite question. So we know for most people, we want to operate. Who do you tell they don't need an ACL tear, or they don't need everybody doesn't need one. Most people don't need one. Who doesn't need an ACL reconstruction? Who do you kind of try to talk out of and say, this may not be of value for you?
Yeah. So like what you said earlier that, after the knee calms down, the knee usually feels pretty good. And people can generally do inline exercises. So, cycling, hiking, some, light jogging even. It's really just that change of direction where the ACL is necessary. And so for people who don't want to do cutting, pivoting activities, they may not need to have an ACL reconstruction. And, the surgery doesn't take too long, but then the rehab, it's 9 to 12 months before you're back to doing everything. And so if you say, well, I don't play basketball, I don't ski, I don't do anything that involves cutting or pivoting, I may not need to have that surgery, may not need to go through the risks of it and then that lengthy recovery, especially if I'm not going to do any activities where, I'll put that structure at risk. And so, I think especially as people get older, it may not, be in line with what they want to or need to do. And then on the flip side, though, there are some people who, even when they walk, their knee feels unstable or they go up and down stairs and it shifts. And so those people, even if they're not trying to play basketball, we're going to, do an ACL reconstruction to make sure that they can do their daily activities without the knee giving way.
Yeah, that's a good point. I think usually what I ask to get that sense of whether or not it's that their quad is a little bit weak or they're actually having instability is it like surprise movements if they're on a hike or they get to the bottom of the stairs and they feel like their knee is shifting. If they say their knee is giving way on every step, then I say, well, that's probably more your quads need to get stronger after the injury. I think that's really important. Oftentimes when I have patients who are on the fence, I'll just say, let's try 3 months of physical therapy, get your hamstrings as strong as possible, really work on the secondary stabilizers of your knee and get the dynamic stability as strong as possible. And I think some of the studies that Drew, you've done show that there's probably a lot more factors than just like, is your knee stable or your muscles strong? There's probably something about the shape of your bones, how your alignment is from your hips all the way to your ankles. And as we start figuring out how these complicated things come together, we'll probably have a much better way to figure out who actually is going to cope well without an ACL and who's going to need it no matter what. And hopefully over the next 5 years, we actually get some of that information, are able to use that in kind of precision medicine for ACLs. So once we take patients to surgery, we talked about it's a pretty straightforward surgery. There's over 200,000 done in the US every year. And I think everybody who's a sports medicine surgeon is pretty comfortable with the techniques. The thing I think that's most interesting for patients is that, first of all, it's a reconstruction for the most part. It's not a repair. We're not just sewing the ends together. We're giving you a new ACL. And then what we really leave to patients most is the idea that you can choose what we're going to reconstruct you with. We can either use your own tissue. We can borrow part of your hamstring, part of your quad tendon, part of your patellar tendon, or we can use cadaver tissue. So Nirav, I know you deal with kids. What's your rationale for, of course, I know you deal with kids since we work together, but what's your rationale for using autograft or people's own tissue for a vast majority of ACL reconstructions in kids under 18?
Yeah, I think there's great data from the Moon study group that shows that using cadaver tissue in young patients has a significant 3 to 4 times higher failure rate. So for younger patients, particularly because they stress the graft a lot more, I typically will use autograft for them. The only time I'll ever use allograft is if I ever have their own tissue and it's not large enough or there's a big enough size, and I'll place the allograft tissue with it. But almost never will I do a complete allograft cadaver reconstruction. And then after that, it's really based for me on their degree of activity and how open their growth plates are. So for someone who's still growing, we can't do a patellar tendon reconstruction because you're putting bone across the growth plate. So then it really becomes, should we use hamstring? Should we use quad tendon? I think there's more and more data, particularly for female soccer players, that using quad tendon is a good option for them. It's a little bit more solid than hamstrings and avoids that knee pain that you may get with doing a patellar tendon reconstruction. But a lot of this is nuances that we'll talk about with the patient and determine the best graft choice for them based on their maturity skeletally and then what their activity level is.
So Drew, when do you decide to use cadaver tissue? What's your either ideal patient or people that you think would benefit most from having cadaver tissue instead of their own tissue?
Yeah, so almost all the time, I think that patients' own tissue is better and stronger. So that will be my recommendation for most people. I think, as patients get older than 40, the differences in the failure rate really seem to get a lot smaller. So the cadaver tendon, it does make the recovery, especially early on, a bit easier. There's not as much pain with the surgery, and you're not having to take another tendon. And so in those patients, I'll still give them the option to use their own tissue, but I think the cadaver is, appropriate in those settings.
Okay, so final question. Nirav, what are you most excited about in the next 5 to 10 years about ACL surgery, reconstruction, rehab? What do you think is going to be the biggest game changer?
I think in general, we talked a little bit about graft options. I think rehab is constantly evolving. We are learning more and more how much we can push athletes, how we can prevent them, and what the best return to play is. So I think, as you mentioned before, the surgical techniques and how we do an ACL is pretty much become standardized. I think learning more about how we can control the risk of re-injury afterwards, whether it be with imaging that Drew's interested in, the particular type of graft for the best young patient, and how quickly we can get them back. It's really how much can we push the rehab process without stressing the graft with basic science data that I think is really, really key.
All right. What about you, Drew?
Yeah, and I think in the future, like we've alluded to, I think we'll be able to do a better job of tailoring both treatment recommendations and then the rehab plans to each individual patient. So we know that there's some people, that can even perform high-level activities without an ACL. Like Hines Ward played professional football, DeJuan Blair played professional basketball, and they had ACL injuries. And I think that at some point we'll be able to tell people, what you need to have your ACL reconstructed if you're going to do this, or hey, you might be okay without it, and be able to tailor that, and then also be able to, give better rehab recommendations. Like we know in general, waiting 9 months after surgery is the best approach, but there may be some people who are ready to go earlier. Just right now, it's hard to recommend that because of increased rate of re-injury. So in the future, hopefully being able to say, it's 6 months, you're ready to go. or it's 9 months, your knee's still not ready, we got to wait, and have some data behind that. And then I think the third thing is eventually like being able to augment this process biologically. So it takes a long time. Hopefully we can have some solution where we can increase that healing rate, or the time that it takes, decrease the time that it takes. So it's not such a long, drawn out process.
Yeah, I totally agree. I think the idea of kind of personalizing the idea of this is what you are like as a patient, therefore we need to do X and Y. I think physical therapists do that great, but it's still qualitative. It's still like looking at like how you're feeling, looking at swelling, looking at how big your quad is. And all things considered, given how complicated the injury is and how complicated the human body is, we still boil it down to pretty rudimentary things. I think what I'm most interested in is whether or not we can prevent the long-term consequences of ACL tears. And I think one of the things, I know, Drew, you're working on this for research, but when people have an ACL tear, the die is cast for their injury. We know that at that moment in time, they are at increased risk for developing arthritis 15, 20, 30 years down the line. If there are ways, in addition to doing the ACL reconstruction, whether it's some sort of biologic treatment, timing of surgery, something to decrease the long-term effects of these traumatic injuries, I think that's what we'll really see in the next 5 years. The problem is figuring these out are really hard because you have to wait 5, 10, sometimes 15 years to see if your treatment strategies of choice are actually taking effect in people. But I think hopefully in the next 5 years, with some of the studies that Drew, you're doing and other groups are doing in eliminating that immediate post-op or immediate post-injury inflammatory cascade will be really important.
Excellent. Well, we could spend several podcasts talking about ACL reconstructions, but hopefully tried to summarize this in about 25, 30 minutes. So once again, thank you everyone for listening to our podcast, and we hope to have you listen to our next episode. Thank you.